Good morning. These are my disclosures, and I would welcome more, and as I'm kind of truly enjoy being conflicted. This is a case study that I think truly illustrates how IMH can behave. This was an 85-year-old female patient with severe chest pain and epigastric pain admitted to our vascular intensive care unit for best medical therapy, as this is always first line of treatment. However, you can see she already had a very thick IMH, and when we repeated the CTA at 4 days later with persistent, with recrudescence of pain, she ended up rupturing her IMH at 4 days after the index admission. This was rapidly treated with a zone 2 TEVAR with in-situ laser fenestration, and you can see the postoperative CTA here showing excellent thoracic aortic remodeling at just a few days later. So, best medical therapy for us is to admit our patients to our vascular intensive care unit with aggressive impulse control with the goal of systolic of less than 120. We do that usually with a combination of esmolol and cardine and control the pain. We repeat the CT scan. In the case of a thin IMH with limited involvement, as you see there, most of the time I think we can be successful with best medical therapy, but in the case of a thick IMH with circumferential involvement, this is where best medical therapy has a significant failure rate. And we published this paper a few years ago. So how often is TEVAR indicated in our patients? It's in the majority of acute IMH that we have to do TEVAR, in a quarter of the patient emergently, but there's a significant number of patients that, and 50% of patients that will fail best medical therapy at a mean of 5.2 days from their admission. When is TEVAR indicated? In our treatment protocol, we do emergent TEVAR in cases of aortic rupture or impending rupture. Patient with severe pain that already have a large aortic diameter. That would be a patient with an existing thoracic aneurysm with a superimposed IMH, or in rare cases of malperfusion. Delayed TEVAR is usually done more for patients with intractable pain or uncontrollable hypertension, or when there's significant changes on the repeat CT scan showing progression of the IMH, or patient exhibiting new or worsening contrast focal enhancements, or significant total aortic diameter enlargement. There's really, until this paper that we published last year, there was no literature evaluating the effect of timing of TEVAR on aortic remodeling and aortic-related adverse event and mortality. So we decided to evaluate the effect on remodeling of doing those emergent aortic intervention, defined as a TEVAR performed within 24 hours of presentation of patient with acute type B IMH. This is a study on 101 type B IMH, acute type B IMH patients. We did 71 TEVAR in those patients. 25 were emergent within 24 hours, and 46 were delayed TEVAR. The reason for the emergent TEVAR, half of them had frank rupture, the other half had impending rupture. When we look at the result of aortic remodeling, what we want is a total aortic diameter to true lumen diameter ratio of 1 that defines a normal aorta. In the delayed TEVAR, you can see that from preoperative to postoperative, the ratio went from 1.5 to 1.1, so showing very good, excellent aortic remodeling pretty much in all patients in that delayed TEVAR group, as opposed to the emergent TEVAR that has much worse aortic remodeling. When we look at aortic-related adverse events or mortality, in the emergency TEVAR group, we had 24% incidence of adverse event. 1 aortic rupture and death, 2 redo TEVAR, 1 retrograde aortic dissection, and 1 endoleak requiring embolization. In the delayed TEVAR group, that incidence of adverse event was reduced to 4.3% only. Only 1 conversion to TBAD and 1 redo TEVAR only. The freedom from AR-EM at 12 months was 95.7% in delayed TEVAR as opposed to 76% in the emergent TEVAR group. So in summary, in acute type B IMH, TEVAR is indicated emergently for rupture or the rare case of malperfusion, and urgently for failure of best medical therapy. In the absence of emergent indication, I think avoiding TEVAR during the hyperacute phase of IMH will lead to improved aortic remodeling and decrease aortic-related adverse event. Thank you.